Hello everyone. Today we are going to do a 2-for-1 recording treatment of urinary incontinence in women. First, it's a little bit longer, a little more going on, and then we will jump in the recording. I was thinking about doing 2 recordings, but this one's only 7 slides, the urinary continence in men. So I'll just tag it to the end of the one on the women. But just so heads up, if you, I don't know if you want both presentations or whatever. First off, for the women, definitions here, some background for everybody. Just make sure you're familiar with these terms. I believe this is going to be terminology you've already been given or will be given in your other courses, ICM, pathophysiology. But anyways, it is something just to note here that is not always adequately treated. There's sometimes a little bit of, again, like with some of the other issues we talked about, so maybe some cultural stigma or something that, and specifically we're talking about women here, that women don't want to come forward with or don't want to talk about, or it's maybe embarrassing or it's a nuisance or whatever. So it is something that, definitely want to make sure you're treating for your patients and make sure you're asking about it. As always, you guys have probably gotten used to this already. Lifestyle modifications are going to be a big thing for this, for the incontinence. Another reason not to smoke tobacco, so look at that. Dietary changes and constipation kind of related to that. So specifically, want to increase your fiber to make sure you are not constipated, or encourage your patients rather to not be, I mean, you guys too. I don't want the students to be constipated either, I guess, but yeah, so you and the patients increase your fiber and, fruits, vegetables, etc. Dietary changes. So specifically there's things that are considered to be weak diuretics. So those are things like alcohol and caffeine, some caffeinated carbonated beverages. So that may be something too that the person may need to be mindful of and maybe reduce their consumption or not have it past lunchtime. Maybe not have it right before bed, or I don't know. It just kind of depends too on the patient and when they're having their specific symptoms and when it's problematic. People are a little touchy about, or they can be a little bit touchy about them quitting or reducing their caffeine intake. So just a heads up on that. But and then weight loss is another one too. So another reason for a person, your patients, to lose weight, eat better, make sure they're pooping okay, they don't have constipation, and another reason for them to stop smoking tobacco. Stress incontinence. So if the lifestyle modifications do not work, then you may need to go to what is called a pessary. And I have some images of those here. So here's some commonly used vaginal pessaries, all different types. You're not going to have to memorize. It's just FYI. I don't know if you guys had seen them before. I'd never seen these before, pharmacy school. So yeah, just this, and it's just basically a mechanical intervention if you want to think of it like that. But there's a great algorithm here that I encourage you guys to look at. As far as my exam, I'm not going to explicitly test you on the algorithm as far as what to do. Definitely, as always, with these little medications, the pharmacotherapy is what, you can put a star by that for my exam. So I won't be testing you on the pessary surgery, some of these other things. I mean, the lifestyle modifications, I don't usually put explicit test questions on, but so definitely please, for this presentation and the one for the men, focus on the pharmacotherapy for my exam. However, as always, I include these algorithms and stuff because I think this would probably help you study for ICM or maybe pathophysiology, but probably ICM. This will probably help you with ICM. Again, just FYI on that. So first off, for stress incontinence, there have been multiple medications. Unfortunately, in the US, there are none that are FDA approved for stress incontinence. That does not mean that you will not be prescribing medications. There are pharmacotherapy. Again, going back to this algorithm there, you notice there are some classes of medications, some medications we will be talking about. So first off, we have duloxetine, which is a generic antidepressant, and generic medication. We will be talking about that a lot more in detail in the psych module this summer. I had to think there for a second, like, when are we talking about that? Yeah, during the psychiatric module. It's not routinely used. However, this is one of those 2-for-1s. Again, you can rationalize using it. So if a patient already has depression and then they're having issues with incontinence, this is something where, again, rationalization, hint, hint for exam questions, so person's depressed with this issue, duloxetine would be a go-to drug. So definitely, I mean, you guys probably noticed by now, if you've taken enough of my exams, I definitely like those types of questions where, you're kind of pulling from different modules, and, you have a patient who has BPH and hypertension, let's say, or in this instance, they have stress incontinence and they are depressed, right? Or they need to be treated with an antidepressant. So anyway, so that's just something to think about. Some of the evidence and stuff isn't so great, but and again, there's no FDA. It's not an FDA approval, but it's just an off-label use. But again, just think about those patients you could rationalize using this for. Other medications, we have the alpha adrenergic agonist, which don't stress about too much. They're not used anymore. They were used historically. That's just kind of an FYI. You may see that in some older references. Same thing with imipramine. This is where there's not a lot of great evidence with imipramine, and there are significant side effects. So this is just more kind of for historical perspective, so don't stress too much about these medications. So other than you may see it, or maybe there's an older practitioner, maybe an older textbook or something you guys are looking at. This is another thing too that I want to note, that I don't ever like to discourage PAs as far as saying, well, you'll never deal this, you'll never do that, or don't worry about this. This is for specialists. This is what surgeon. I believe that you guys should be exposed to as much as possible in PA school, as even if it's. But definitely, this is something that you will be able to treat, inpatient, maybe outpatient a little bit. However, please, recognize your scope of practice, and it's just going to depend on where you're practicing. But then, some of these women who are not, responding well to the lifestyle modifications, and then you prescribe, a medication and they don't respond to that, it may be something where you do need to send them to a specialist. So again, following through this algorithm. And again, that's just FYI and just something that want you guys to be mindful of. So of the medications you guys may be prescribing, first line, we have the antimuscarinics. So those are medications that can be beneficial. If those patients aren't able to tolerate the antimuscarinics, you can go with the beta adrenergic therapy. We talked about in another presentation, and I believe it was in the BPH lecture. Yeah, so please go back to that. There's some more information on that, but that's the Mirabegron. And so, yeah, to get more information on that, it's a beta 3. It works on the beta 3 receptors. And then just note too that you always have to think about cost, adverse effects. The other lifestyle modification we talked about before, but is the Kegel exercises. So that's his pelvic floor exercise that can help these women. So that is something that I believe they talk about in ICM, but if not, let me know and I can get you some more information on that. But the pelvic floor exercise is another lifestyle modification, and it's definitely something that should be done throughout. So even once the person has been prescribed so once you guys prescribe something, then you still need to encourage the patient to do the lifestyle modifications, and specifically continuing the pelvic floor exercises. Antimuscarinics, we talked about, or we mentioned that those are going to be some of your first line medications you can go with. And this is just how they work here. So just going to read through this. So you consider this mechanism of action, if you want to label it that as such. They are not the best medications. They do rarely resolve all symptoms, but it is still something you can use. And again, it is, like I said, that we still have take into consideration that there aren't FDA approvals, so you're not going to have a lot of great medications. But anyways, I mean, but these work, and it just, and I guess the other thing too is when they say they don't resolve all symptoms, it's part of that, part of the recommendation with the guidelines where you need to always be doing the lifestyle modifications and those pelvic floor exercises while you are prescribing these medications. So there's 6 here that are antimuscarinic medications. We have see those on the slide next. If you're practicing in Asia, they have this one that they use. All the efficacy seems to be similar on all these medications. And the big difference here is, and let me see real quick. So kind of a small table here, but definitely please make sure you look at this table and you study this for this section. Medications, starting dose, you don't have to worry about that. Maximum dose, you don't have to worry about that for my exam, but still you can go through it. And then selected characteristics, definitely go through and look through there. And we're going to talk about adverse effects there. So I definitely want you guys, because adverse effects are a big deterrent for these medications. So these all have anticholinergic adverse effects. So dry mouth's a big problem. The good news is that so they have immediate release products, which are IR, extended release products, which are ER or XL or whatever, and then they have topical or transdermal. So the way it goes here is that there are the most adverse effects with the immediate release, there are less adverse effects with the extended release, and then there are even less adverse effects with the transdermal patches or the topical gel or whatever. So if you want to go ahead and write that out, definitely please put a star by that. Please note that for exam purposes. I definitely want to make sure you guys know that. And so majority of prescribers will prescribe the long-acting oxybutynin, for example, or maybe the oxybutynin patch or the gel, right? Because of less adverse effects. So definitely something to be mindful of. The extended release products have less adverse effects than the immediate release products, and then the topical / transdermal products have less adverse effects than the than the extended release. So anyway, so if you want to write it out from left to right, you can write immediate release and then do the alligator mouth, right? I'll show you real quick. Okay, there's my awesome artwork. See, Dad, I told you I could be an artist. No, I'm kidding. So adverse effects, just to make sure everyone gets this, because definitely testable material, and I've had students in the past had questions and concerns about it. So, and pardon my shaky handwriting, it's hard to write on this laptop, but adverse effects for these antimuscarinic medications, immediate release has more adverse effects than the extended release or, extended release products. And those have more than the transdermal / topical. So T is for topical. So those are your gels, your patches, etc. So hopefully that is clear. Please put a star by that. Let's see if I can draw a star. Bum, 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 bum. Oh, no, it doesn't. Dun, 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 dun. Star music, star music. Okay. That's probably really annoying. But yeah, so put a star there. Definitely want to make sure you guys know that. And just to star this whole table, this has got a lot of good information. Definitely these selected characteristics too. Please squint at those, look at those. And always too, I think I've said this before, but with the up-to-date tables, always read the fine print. They got some good stuff in there. And it's still important. So hopefully that is clear. If not, just email me and I'll hopefully try to make it a little bit more clear. All right, got some pearls for you guys for the antimuscarinics. This is something that you are going to want to start low, go slow, which we've seen with some other medications. So it just basically means start with the lowest dose and then titrate up as needed, Q2 weeks. And the reason for that is lower doses typically have lower chances of adverse effects as well. Just please note to your patients that it may take up to 12 weeks, which if I can do my math correctly, that's 3 months, right? For medications to have their full efficacy. So that is something that, you need to think about and be mindful of, and don't DC the medication, just because, it hasn't worked for a month or two. Again, try to be mindful about giving it its full 3 months, which I'm hesitating a little bit because I know it can be frustrating for patients. Had patients in the pharmacy be like, well, I'm not going to pick up my refill because whatever, it doesn't work, but so anyways, encourage them to do that. Oxybutynin, like I mentioned, is going to have the fewest, the patch specifically, so that transdermal is going to have the fewest side effects of dry mouth and constipation. So definitely put a star by that. Want to make sure you guys know that. So they all are they all have the peripheral anticholinergic effects, and that's why their adverse effects are so bad or so, intolerable, I guess to say. People don't like the dry mouth. Xerostomia is another word for dry mouth. It's very bad dry mouth, right? Constipation, blurred vision, tachycardia, drowsiness, decreased cognitive function. So all things that people do not like to live with. Also, please note, contraindicated with gastric retention and then angle closure glaucoma. So definitely for testing purposes, make sure you know that. Another thing too concerning, especially for your elderly population, they have been associated with dementia, and that's kind of related to the decreased cognitive function too. Those can both be problematic for your elderly population. let alone these adverse effects are going to be problematic for elderly and non-elderly population. These are just problematic anticholinergic adverse effects. So definitely please take on point, make sure you know that. With these antimuscarinics, you're going to have to be thinking about in counseling and kind of looking to help mitigate the adverse effects. And like I said, so some of those strategies are to do a topical or transdermal product if you can. And then the other thing is to start low, go slow with your dosage and maybe titrate up. So anyways, dry mouth is a common reason for discontinuation. So again, it's very severe. It's not just like, oh, I need a glass of water. Let me take a little sip on my tea here that I'm sipping on. But actually I will take a, oh, that's a good idea. Yeah, it's like I was like mentally like my mouth was super dry because I was talking about it. But it's not like that. Like I just drank and went like whatever. It's like super dry. Like your lips are stuck to your teeth, and it's just it's painful. It's not nice. But anyways, the constipation and the fluid intake may actually make the symptoms worse. So it's another thing where those adverse effects are actually making it worse. And then, like I said before, extended release formulations have fewer adverse effects and then lower rates of discontinuation. So please make sure you know that. Next up, we have the beta-3 agonist. This is the one, the Mirabedric is the brand name for this one here. And this is one that is going to be second line to the antimuscarinic. So if a person has a contraindication, like we talked about before, or they can't tolerate the side effects, etc., or they have an allergy or something, this would be your second line one to go with. And like I said, there's more information on this medication in the BPH lecture during this module, so please go back and make sure you're studying everything that's listed for this medication. We have some dosaging stuff here and some about its effectiveness. Just go ahead and read through that. Just FYI, you're not going to need to memorize dosing for me. Adverse effects. Definitely note, and this is in my other presentation, that patients should not be prescribed this if they have severe or uncontrolled hypertension. And please refer to the other presentation for the details on why that is, but just basically it makes it worse and it can be dangerous. And so, yeah, that's something to be thinking about. Combination therapy is a potential strategy. So first line would be your antimuscarinic, second line would be your beta-3 agonist, but you could also do a combination. They make some combination products, maybe a little more expensive, but they can be something where they, if they're not responding to either of the agents as monotherapy. Then we have our summary recommendations. As always, just go ahead and read through those. Oh, and here's the other name for that. I said Kegel, but the pelvic floor exercises is also known as a Kegel exercise. And men and women can both do it, but it seems to benefit the women. And just go ahead and read through the summary recommendations. So we are now going to jump to urinary incontinence in men. So get your presentations ready. I used to have to wait for students in real life when I was there in person, because you could like shuffle, even though it wasn't paper, just shuffling on the iPad or whatever they were using. Okay, this is going to be it's a little bit different, but just please note it. And yes, please study the differences, or please study both these presentations. I've had students in the past ask me about that, but yeah, please look at both. I'd appreciate that. Thank you. Don't shut off the video just yet. This is something where it is less common in men than women. However, it may be more detrimental, I guess, or it has a bigger impact on the quality of life for men. So it's just a heads up on that, but I'm going to read through all the introduction. Management, we have the lifestyle modifications. So the weight loss and dietary changes are going to be good. Bladder training, biofeedback, and then also those pelvic floor muscle exercises, like I said, can be effective. As far as their efficacy is concerned, there isn't a ton of evidence, but it is still reasonable considering that they're free usually or low cost. And then some of the things too, like quitting smoking tobacco, losing weight. I mean, it's not going to, or having a better diet, it's not going to hurt these patients too. So just as with the women, go ahead and start with the what's it called? The non-pharmacological or the lifestyle modifications. Next up, we have the pharmacologic therapy. We have the alpha blockers, antimuscarinic drugs, and then the serotonin norepinephrine reuptake inhibitors, which these are the ones we haven't talked about yet, but those are going to be in the antidepressant section of the psych module. So first off, we have the alpha blockers. So this could be something that you've seen some of these already in the BPH lecture. So definitely I mean, you guys can listen to these in any order you want, so I'm not going to tell you what to do. But if you want to know more about these alpha blockers, and I talk about them a lot more, please refer to the BPH lecture. So this is going to be one of the main differences between men and women with this incontinence is going to be the men. You can use the alpha blockers because of, and basically it's, because older men maybe have this issue with incontinence, and then, like I mentioned in the other presentation, older men typically will have issues with BPH, and so it's kind of again one of those rationale you can make. It's a 2-for-1. So the patient has stress incontinence or has incontinence, and the male patient, and they have an enlarged prostate or they have BPH. This is one of those where you could rationalize starting with as first line an alpha blocker. Usually well tolerated. We talk about adverse effects a little bit more in the other presentation, so please go to look at that. But hypotension and dizziness, and then please note too, in combination with some other medications that can cause hypotension. So definitely put a star by hypotension with these alpha blockers. Antimuscarinics, so we talked about this already with the women, but these can be used for men as well. So everything is the same as for what I said for the women, as far as their adverse effects, as far as the extended release versus immediate release versus the transdermal products. So please I'll just go back to that presentation, but it's the same presentation. It's the same day. We are live, real time. No. So this, so a lot of this can just be transferred over. So this will hopefully make it easier for studying. So the good thing so far, alpha blockers, you're already studying those for BPH. So not too much new to learn, but those will be first line for your men. Then second line, antimuscarinic drugs, which, will be first line for your women, so a little bit different there. And then we have our summary recommendations, so you can go ahead and look through this. You notice too in the summary recommendations we have the duloxetine again, and that is the serotonin norepinephrine reuptake inhibitor. So just know it's there. It's kind of on the fringes, and again, it's going to mainly be for those people that need an antidepressant and then have the incontinence. Again, kind of a 2-for-1 kind of recommend, but definitely go and read through these summary and recommendations. And that is it. So thank you guys. Was I a little too excited there that I was done? But I always get a little excited when I get done with these. That was it for this presentation. So as always, please feel free to email me any questions, comments, feedback, whatever, other stuff that you just find interesting or enjoyable. No, I know you guys have no extra time now, so there's no interesting, exciting things you guys are doing outside of school. That's how it was in pharmacy school for me too. But anyway, so yeah, you can email me other stuff too if you'd like. Thank you guys for your time and attention, and I will talk to you guys later.